Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself. I'm the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. Chadi, you want to introduce yourself?
Thanks, Brian. Chadi Nabhan, a hematologist and a medical oncologist with academic interest in all lymphoid malignancies, obviously including CLL. I'm currently the Chief Medical Officer and Head of Strategy of RIGHT, which is a generative artificial intelligence company bringing artificial intelligence and technology into clinical research operations to hopefully we can improve the ability of patients to get access to that. And in my spare time, I do my Healthcare Unfiltered podcast and I write books when I can. And I'm sure we're going to talk about the cancer journey.
Yeah, I just finished reading The Cancer Journey, and it's encyclopedic in its approach, but I'm going to pull out one chapter right now, which I thought the anecdotes that were in this, the stories that you told in it were just amazing. And I've been a big advocate about doctor-patient communication. We've done some research on that. You told some stories in there, and you talk about shared medical decision making. So tell us a little bit about this, and if you could focus on maybe something that's more related to the CLL patient that might be helpful for them in terms of how you help patients through those decisions, because you've been doing this for decades.
Right. So broadly speaking, we all know communication is very critical, and the recipient of how you communicate is the judge of whether you're a good communicator or not. I mean, frankly, Brian, similar to writing a book, if I'm writing a book, I may think it's really the best book out there, but if the reader doesn't think then I'm writing the book for readers, not for me. So communication is very critical, and it's a very broad category. In that long chapter on communication that you refer to, I share stories where I thought I did a good job communicating with patients, but the patients or the families did not think so. And I took it to heart. I actually, some of them sent me cards afterwards that were not too nice. And to this day, I have these cards. I actually read them every so often to stay grounded and humbled and to remind myself there's always room to improve. And we should really think about this. I've never taken any situation lightly. I don't think a physician, when they have a dissatisfied patient, should say, well, I've done everything I can. Maybe you have, but if that's not transmitting, maybe then the link that is missing is how are you communicating that you have done everything that you can? That's really the key. I'm not doubting that all of us are trying everything that we can to help people. But if people are not recognizing this, let's not jump into conclusion this is a difficult patient or a difficult family. Because frankly, you never know as a doctor when you are in that patient's shoes how difficult you're going to be. And so let's assume maybe there's a way that you could communicate better. So I share many stories in that chapter where I was as honest as I could be in scenarios where I felt there was a breakdown in communication. There are situations where I felt I could have done better and things of that nature. On the CLL, in the CLL world, there's a lot of things to communicate, and I share that in a couple of areas in the chapter. One of them under the cancer staging, when a patient comes in and I told him he had stage 0, and he's like, "What are you talking about? You're crazy. I mean, this is not the way really it works." And you have to really sit down and just explain that scenario to why, what does that mean, and things like this. So again, it's the way you communicate, because if you don't communicate effectively, this is going to your patient is not going to trust you. My last comment on this is communication is key because the cancer journey is never smooth. There will be situations where things are just not going to go well. There's no question. Sometimes people will have complications. Sometimes things just don't go well. The patient end up in the hospital. Whatever it is, there will be bumps in the road. And if you have that clear path of communicating with your patient's going to maintain that trust with you even when things are not going well. If the communication is not good, then that trust is going to break. But I'm glad you mentioned that chapter. This is a very dear chapter to me. It's probably the one I spent a lot of time on it, and I there were a lot more stories I could put in there. I think I tried to be brief, but I think everybody who will read that chapter, they can relate to it.
And you certainly bared your soul in that chapter. It was very moving, I thought.
It was cathartic. As I remembered some of these stories, like I said, I still have these cards. And like I said, we all have, hopefully, a lot of thankful people and people who just tell you, thank you for saving my life and all of that. And that's great. We can always like pump our chest and think we're the heroes. But you know what? If there's one patient that you failed because there's something that you could have done better, maybe it's time for self-reflection. As I wrote this, I did recall, the first story when I talk about the patient's wife who was yelling at me at the ICU. Believe it or not, Brian, it's been probably about 15 years. And I remember that story as if it was yesterday. I remember her features. I remember the patient. I remember his name, his last name. I remember all of that because these are stories that just stay with you. Not, I don't want to say because they're traumatic. I would say because to me, I felt somehow I failed this family.
Right.
And if there's an oncologist who's reading this, if there's any physician or a fellow or a student reading this, I just want them to take a note that it doesn't matter how wonderful academically you are and how many hundreds of papers you wrote and how many greeting cards you've got. If you have one situation that did not go well, stop, pause, self-reflect, and see what could have done better. And maybe the answer is nothing. You've done everything you could, but at least reflect a little bit and ask yourself that question.
And I would say, and putting an explanation point behind this, that as physicians, we are more informed by our failures than our successes. When I think about how I approach a patient, I think about the patients that haven't done well and how to avoid that in the patient in front of me right now. And obviously, we're informed by this worked before, this treatment worked for this patient. But the patients where things haven't worked for, I think, really inform your decision how to become a better doctor. I think is very much informed by the cases that don't go well, even more so than the cases that do go well.
I couldn't agree more. I totally agree with you. I think we should learn from the scenarios where we just fell short.
Let me ask you something related to communication that you touch on, and maybe you can help define this for us and explain how it works well. What is shared decision making? How do you approach that as a physician, especially as a hematologist oncologist? This is a huge part of your day-to-day practice with patients.
And also in CLL is also critical because there are lots of new treatments, thankfully, for CLL. And I think I think I was very transparent about my views on shared decision making, which is there's absolutely at the end of the day, the patient has to make the decision. But how much I mean, you cannot take away 20 years of medical schools, training, and hundreds of CLL patients you've taken care of and assume that the patient is going to make that decision based on really no expertise and no knowledge of the biology of disease. So I think the way I've approached it is that there are certain elements that the patients have to decide on that I cannot really decide for them. But there are certain things, it is my duty, it is my fiduciary responsibility to tell the patient what is right or wrong for them because there's no gray area here. This is right and this is wrong. Now, if the patient chooses the wrong for them because that's what they want, that's totally fine. But I cannot really tell them, well, let's decide which one of these two if I know one is wrong. I'll give you an example, a couple of examples. One example is I had a patient when I was doing general oncology who needed chemotherapy. She was 80 years of age, and I definitely was convinced chemotherapy is going the next step for her, but it was going to cause hair loss. And the shared decision making here is that it wasn't that she could have declined chemotherapy, but we actually agreed that we would choose a chemotherapy that is inferior than the one I was going to give her because she wanted to maintain, she did not want to lose her hair. There was a decision making where me and her sat together and decided on this, but ultimately my decision was that this is right. Chemotherapy is right for you. This was not a decision that this was the appropriate medical decision. And then she's going to come back and tell me, well, it may be the right decision for everybody else, but for me, it's not. Because it is the right decision based on studies that include all patients. But for me as an individual person, it is not aligned with my values. It is not aligned with what I want and things like that. So there's a lot of this dialogue that needs to take place. And I think sometimes we put a lot of burden on patients to make these decisions. Patients cannot decide which type of chemotherapy to choose. They can decline chemotherapy, but if they choose they're going to get chemotherapy, then I have to decide. There's a lot of intricacies here. Hopefully, I didn't complicate things, but I think the book really outlines it very nicely.
Yeah, and you have a really nice discussion and examples of this. Dr. Nabhan, I'm so pleased that you took the time to write this and reflect on this. Thanks so much for all you're doing.
Thank you. I hope people like it.